long COVID?
So during the 2020 engagement programme, we had a particular focus group and gathered information from people living with long COVID at the time. In the subsequent years, we were continuing to hear from people living with long COVID through a range of different forums and groups that we were members of, that the experiences that they'd had then had continued. So in terms of the support they were receiving, the challenges they were finding in terms of the awareness of the condition, really the range of symptoms and those experiences being believed and understood. And also, despite some of the policy developments around long COVID service across Scotland, people weren't necessarily describing that they were then experiencing that support as available in their local areas. And so we commissioned this research really to understand in a bit more detail what people's experiences were, further on, so a couple of years since the onset of the pandemic. And
can you perhaps just very briefly explain what the outcome of that research was?
I think the things that really stood out from that research was that people were very much, I think, shocked by the experience they had of being diagnosed with a long-term condition, and the challenges that they'd encountered with having that experience believed by the healthcare system. They raised concerns about battling to receive a diagnosis, that the range of symptoms that they were experiencing not really being accepted as part of the condition. They talked about the significant impact that it was having on their daily life. Many people having to leave work, having to rely on friends and family for support with the caring responsibilities that they had in life. That they were having to spend a huge amount of time researching support and treatment options, some describing having to look for private support and treatment. Some did describe support that they were receiving from the health service and good support from GPs and others. They typically tended to refer to themselves as being lucky for having that experience. And when they were discussing wider support, they spoke at length about the difficulties they'd had navigating the social security system, and none that we that were involved in the research that I can recall had any experience of accessing social care support. It had not been a route that they'd found accessible for themselves. Yes, I think one of the things that struck me from listening to people's experiences of living with long COVID was that they were overwhelmed at the fact that their experiences initially were not believed. They received feedback that, they couldn't still be living with symptoms. They'd had COVID, months ago. How could they still be describing these symptoms? There was no place to go to get support, to get information. They were having to do all this research by themselves. And that is, why we have seen the numbers of people who are, connecting with peer support groups, online groups, etc., so that they can share the experiences of the research and the support that they have found. I would also say it's not an experience which is unique to long COVID. I think, working with the Alliance for the years that I have, that feeling of being invisible is described by people living with other conditions as well, particularly conditions which are perhaps harder to diagnose. There might not be one recognised test or procedure to diagnose a condition, such as people living with ME, chronic fatigue syndrome, people living with endometriosis, other conditions that, those experiences. And I think that's coupled with what we were talking about by, dominant messages in the media and publicly, that there was a perception, not by everyone, in the kind of public narrative, but a feeling as though this was a made-up condition. This was not a real condition, and I think that has just compounded those experiences for people, feeling as though their lived experience of this has just been completely overlooked.
Impact on unpaid carers.
I would say that the impact has been profound for unpaid carers. There's, I guess, just to express, these are family members, these are loved ones of people that they also provide care for. There was almost a juxtaposition in one respect. Unpaid carers were and felt very much excluded from arrangements, from decision making, from decisions that were taken about people's care and support during that period of time. So they very much described experiences where their involvement was just sidelined. And yet, at the other side, they also were in a position where they were left very often to provide significant amounts of additional care to family members because of the disruption to other, support and care packages that people had access to. Many, described that they were, having to provide almost round the clock, 365 days, 24 hours, care and support to loved ones. And also at the same time, for example, people who were caring for disabled children, they were also having to provide education and schooling support. They were, despite the significant role they play, they were not able to accompany loved ones to healthcare appointments and to be there when information was being provided, when people were accessing healthcare and support. And we also heard experiences, as I'm sure you will hear more about as well, from people who were important part of a person's support when living in a care home environment, and all of a sudden being excluded from being able to be part of that care team during the period.
Media perceptions.
The way in which the risks associated with COVID-19 were presented in the media and in public narrative led to almost a perception that for the majority of people there was not much of a risk to be concerned about with regards to COVID-19, and it was something which only the vulnerable had a reason to be concerned about. I think in addition to that, what we heard was that the way in which it was presented as something which, it was older people who were at risk of, also meant that many people, living with disabled children, people who were higher risk because they were immunocompromised, and for other reasons, their circumstances were overlooked and they weren't seen as visible in terms of the risk that this presented for them. I think there was a huge amount of concern as well that, if it's okay to I guess, expand upon this in respect of many people living with long-term conditions and disabled people feel almost systematically overlooked in society. Anyway, there was we heard from people during our engagement that the restrictions imposed upon everyone in society gave people an insight into what it is like for some people already without those restrictions, just because society is not accessible for them, and so there was almost a sense of a levelling down, if you know what I mean, that people were feeling like, well, this is, more people have, an opportunity to see what it's like when you are isolated because of how inaccessible society is. So the portrayal in the media that this was something that only those who are vulnerable need to be concerned about represented a narrative which many people already encounter in society, that their rights to live, the same quality of life as anyone else in society, is something which is undermined or overlooked. So they felt that the narrative that don't worry, most of you are okay, carry on about your business, actually really made it so that those who were at higher risk had to be extra careful, extra cautious in the choices they made. And I would add that is how people still feel, for those who feel really concerned and that they feel, very much still at risk from the impact that COVID presents to them, that now they are having to make and navigate those decisions really by themselves without a huge amount of support available.
Accessible communications and information.
I think the other thing that we that is really important is that there are feedback loops. So we need to know that when information is provided, that it reaches those that it's seeking to reach. One of the things that we also found, and I think was quite successful during the work around the vaccinations, was that by working with voluntary and community groups and organisations, those where they have existing relationships, where there is trust in place. One of the things that was fed back around that is that, for some people there isn't necessarily the relationship and the trust with some of our institutions, and with the amount of misinformation that was also coming out, it was difficult for people to discern what to trust. So those organisations and groups where they have that trusting relationship, is a really effective way of information being cascaded. There was also the opportunity to be quite, outreach focused and, considering, different mechanisms for getting information out to different parts of society. And I think that was one of the things that we were, really concerned about, was that people felt what they were hearing nationally didn't chime with what they were experiencing locally. They were finding it very difficult to find the information that allowed them to understand what they could and couldn't do, how to stay safe, and also that they were finding that with regards to the circumstances that they faced in life, so having a health issue arise, a worsening of a symptom, some matter relating to their health or their social care needs arise, they weren't sure how to access those services and contacts in the health and social care system. They weren't able to find out what services were available, what weren't available, where they were in terms of waiting for care and treatment. So there was kind of a huge range of factors around the communication that people raised with us.
Digital choice.
So I think this was, when we were talking right at the start about learning from innovation, increasing the access points through digital health and care tools and technology was something which, as an organisation, we were very aware the health and social care system had been seeking to take forward for, over a decade. And yet the pandemic really was a catalyst for accelerating the access points through digital. Through the engagement that we had, many people really welcomed that. They felt that the choice that they had around, how to access their GP, how to access other aspects of the health service, particularly if they were living in remote and rural areas, not having to travel to appointments. That was really welcome. On the other side of that, there was many people described feeling as though they were concerned that the blanket use of a digital first approach felt really challenging for them. There were some examples where people were receiving physiotherapy, for example, through the virtual video conferencing technology platform, and they felt it didn't meet their needs. It wasn't particularly tailored. They weren't following what was being provided. There was I remember a family member of a disabled child saying that it was pretty much they were just left to deliver the physio to their child without the support that they usually would be getting. There were people who said that they were having lumps or symptoms checked out via the video conferencing technology, and they were concerned that was they were concerned about trusting the diagnosis at that point, because they didn't feel that if someone hadn't actually been able to see, to feel, to really assess whatever the symptom, whatever the scenario was for them, that they didn't trust that it was the same standard of care that they would have had face-to-face.
Do not attempt CPR, brackets, DNACPR. I
think, we recognise, as an organisation who, we've been working around, this and similar issues for many a year now, and people understand that anticipatory care planning and planning for end-of-life care, is something which, is a real matter people will engage with and need to engage with. The way in which it was handled during the pandemic with calls, there was one mum who shared an experience where she received this unsolicited request, and it was about her child, and she was told that this form was going to be applied to her son, and there would also be no hospital transport in the event that he needed support to save his life. And it was delivered to her pretty much as a cold call, extremely distressing and traumatising for her, and has left her really questioning the support that is available for her and her son, now and in the future. We call in, and I believe we'll cover this in more detail, but consistently what we hear from people is that they are looking for a greater sense of person-centredness in the care and support that they receive, navigating the healthcare system, particularly when their circumstances, will require them to have, repeat or frequent engagements with the healthcare system. So it's not that people want to overlook these issues, or that they're putting their heads in the sand or anything, but that they want to have a meaningful conversation with a healthcare professional about these issues ahead of time, not at a point in crisis, and not in a way which is about protecting the service, not protecting their life and their rights.
I suppose, given using the example you gave, I suppose there is a necessity to discuss those matters, but there is a way about how you should do that.
Yes.
And that probably was not the way to do it.
Yes, absolutely. Yeah. And I would add, there is guidance around anticipatory care planning. There has been a programme of work which Healthcare Improvement Scotland has been taken forward. Gosh, a number of years ago we were involved, so I would say several years, maybe dating back even to kind of 2016 or around that time, to try and increase the use of anticipatory care planning across Scotland. So this was something which, again, need not have been an issue during the pandemic if it had been implemented in the way in which the guidance said, that this is about having early conversations with people, not just about their end-of-life care wishes, but about how what's important to them, as they progress through life, as their health maybe deteriorates, as it's not just about as things get towards the end, but really about planning for the future.
Shielding.
So I think initially what people found confusing was whether or not they were on the shielding list to begin with. I think there was, there was a situation where, down to what data, coming back to what data actually was held nationally on people across across society through the health service. There were some people who were identified as on the shielding list and received a letter accordingly. There were others who were able to be added on because of they were liaising with local GPs, other healthcare professionals. We also, through our links worker service, were aware that through relationships that links workers had with different members of their practice population, they were able to advocate for the inclusion of members onto this list. So there were some people who thought they should have been and weren't added on. They might also be in contact with someone else whose circumstances were quite similar, but they themselves were in a different situation to someone else. And of course, being identified on this list meant that they had access to, documentation which they could use to share with their employer, with others, to identify that they were shielding. It gave them, they were able to access local support as well, to counter some of those issues around isolation and access to, essentials. I think as well that the way in which the process was managed as the pandemic progressed and the shielding list transitioned into a higher risk list, and some of the communications then that subsequently came out to people felt confusing to them, particularly what they should be doing, could be doing, shouldn't be doing, and the point we're making here was that this was exacerbated by the fact that the way in which restrictions were eased and continued to be implemented differed, whether you were living in Scotland, which part of Scotland you were living in when restrictions were locally applied, and if you were living in different parts of the UK. So trying to navigate that, the complexity of it was perhaps inevitable, but, being able to make the right decisions based on your circumstances was critical for people. So they needed to have access to that information to be able to know what they should be doing, could be doing.
Third sector impact.
What many areas experienced was just the challenge with capacity. There was some problems in just being able to go through commissioning processes because they were having staff were being relocated. There were financial pressures as well on areas because they were having to provide for different responses than what they had been used to be doing. There was also an impact where organisations were not seen as essential, so they were furloughing staff because there wasn't, this was not seen as a kind of part of the essential services that were available, and also the impact on many third sector organisations financially was also really challenging. Some of their provision will have been supplemented through fundraising, through charity shop, sales, through volunteering. That was really, really difficult to manage during the pandemic.
Third sector not being valued.
I mean, I think, one of the things, and it wasn't just, as a third sector intermediary, we would of course be, celebrating and pointing to the good work happening in the third sector during the pandemic, but we weren't alone. Scottish Government, Healthcare Improvement Scotland, also provided reports and research which documented the very agile, flexible and at pace response that the sector provided to support people, often in really significant ways as well. That, I think the other thing that we saw during the pandemic was that funding was provided without the kinds of strings attached that you typically see through either grant funding or through, contracts and service level agreements, whereby, organisations were trusted to respond to the needs they were encountering locally. Organisations really appreciated that. They adapted quickly to provide for the kinds of basic needs that they were encountering. When we refer to that being almost the exception in terms of the value placed on the sector, what we see and have seen for many a year is that the contribution that the third sector makes in terms of community health provision and as a provider of a lot of social care support and services, we tend to not be included as a matter of course in decision-making bodies, in governance and oversight boards and bodies as an equal partner. The kinds of agreements, we've recently heard of one local authority area that is going out to re-tender for a service at a lower value than it currently provides that service for, despite the fact that costs of delivering services for all of us have gone up. We are we're not referenced. Typically, there was the Health and Social Care Workforce Strategy by Scottish Government. The third sector workforce does not feature within that, where it tends to be recognised as a contributor to our health and social care system. By and large, that tends to be within the social care sphere. But there's a huge number of organisations that deliver a whole range of support for people's health and well-being, ranging from peer support groups and provision to really specialist support. There's organisations that provide rehabilitation and habilitation support for people with sensory impairments. There is, really specialist support for people living with, neurological conditions, befriending support. The response that was provided during the pandemic relied on that ecosystem within the third sector. And I would be really concerned that the way in which the sector is treated and the resourcing that goes into it, the lack of long-term funding, the lack of planning, and real understanding about there's waste in the sector caused by the way in which the sector is treated, that provision might not exist if we don't make sure that we're looking after it.
Spirit of collaboration and third sector funding.
Examples that were given both by representatives from health and social care partnerships as well as people working in the third sector was that there was a spirit of collaboration which was enabled because we were all united with a common goal. And organisations, I remember one organisation saying, the Health and Social Care Partnership is actually coming to me to say, how can we work together on making sure that, we're reaching people, across society? Can we work together on these matters? So that was extremely welcome, from all sides. As restrictions began to ease and we began to kind of plan more for recovery, There was a concern at the time that we might not be able to learn those lessons quickly enough and implement them so that they become more business as usual. So there was direction set nationally, which allowed for perhaps some of the procedures that would typically be in place to be loosened, so that it was more about responding to those kind of emergency needs. That concern, I think, is definitely being evidenced by work that's happening locally. I was referring to one, an organisation who was concerned about the arrangements for the recommissioning of a service for particular service provision around social care, and they were really concerned that they were being expected to tender for that service at a lower cost, which would not allow them to reflect the additional costs that have just been incurred because energy's higher, rents are higher, but also actually pay their staff an increase because their costs will have also increased. Personally, as an organisation, we're seeing that as well. One of the services we deliver in Glasgow, an example of a very person-centred support, the Community Links Worker Service, and because of the funding pressures on national government and locally, that service provision is being cut. It's not just about the cuts; it's also about how those decisions are taken. So, we were not consulted, we were not involved in the decisions around that. The staff weren't involved in those. The people accessing those services were not consulted. That goes against guidance. It goes against what you would witness if it was a public sector employer. There are different standards. Depending on whether you work for the public sector or the third sector, an independent sector in health and social care.
Social care experiences.
Reflecting on what we were talking about around flexible working and some of the spirit of collaboration around with local authorities and health and social care partnerships, another aspect which people shared with us quite substantially was their experiences of their social care packages and accessing provision around social care during the pandemic. We heard from people that without much notice or any notice that their social care packages would be stopped, that was communicated without an explanation, really, or without any alternatives about what else would be put in place, and again put quite a lot of pressure then on family members and people providing unpaid care. There was guidance which allowed local authorities and health and social care partnerships to lessen the requirements around an assessment or the extent of the assessment that had to take place. The guidance was that was to expedite the process and make sure that people were able to access the care they needed without lengthy delays. Yet, in practice, sometimes what that led to was, people, those assessments not being communicated to people in a way that provided them with the information about what they were going to be able to access, and also seemed to then lead to a tightening of the eligibility criteria, so that they had to meet a higher threshold in order to access social care. There were also some examples that some local authorities had suspended their complaints processes, which again is a really important process that allows people's rights to be protected if there were concerns that they had about the provision that they were receiving, and that was raised by ourselves and the Scottish Human Rights Consortium, that this was not acceptable. There were some examples, so I would, I spoke to some of those beforehand where, there were some positives around, greater flexibility for social workers making decisions. There were also some opportunities where people were able to use their personal budgets more flexibly to help them meet some of the aspects of their daily living needs and circumstances, maybe to employ a family member as a personal assistant, which again allowed them to have some choice and control during that time. I think that was one of the things that we kind of advocated for strongly, was that the experiences around social care were given, due consideration during the inquiry process, substantially because the way in which decisions were made were really difficult to track and to monitor for organisations and for people accessing social care. And, for many people, social care is about enabling them to live an independent life and be able to participate. It's a hugely critical, provision of support and services for people. So, those experiences are really important that we hear about as well.
Human rights standards and person-centred care.
I think with regards to the first point about embedding human rights standards and principles into decision making. I know that the World Health Organization emphasised, people's participation within, a pandemic's, preparedness and decision making. And whilst, I think we and our members can understand that decisions, particularly at the outset, had to be made at pace. There was too many occasions where blanket approaches were applied and there were not opportunities taken to involve people to understand the implications on their health and well-being. Human rights standards don't tell you what to do in a particular situation, but they can provide you with parameters and, really welcome standards to allow the tensions between, rights and risks to be surfaced and to be thought through. So, we're not making that recommendation as if it would be, it would provide all the answers, but it provides a really important framework. People's rights, even and perhaps especially in pandemics, need to be protected and respected. I think one of the other things when we're saying about people whose rights are most at risk, those people most disproportionately impacted, that was not unknown. It was not not a surprise, but it wasn't to be unexpected. When we look at the evidence about those experiencing the greatest impact of health inequalities in Scotland, these are the same groups in society who were most disproportionately impacted by the pandemic and the response taken to it. If we are to be better prepared in the future, that means addressing some of the ongoing population health crises that face us around, people's access to the building blocks of health. It's vital that we address, some of those risks that people continue to face. And I would also add that, I've referred to it at previous times during this statement about the desire many people that we represent have for, greater person-centred care and planning when they are navigating the health and social care system, and particularly, around healthcare. There's not enough examples of person-centred planning, continuity of care, the importance of recording that and, understanding tracking the data around, people who access our healthcare. It should not have taken the efforts it took to identify those people who needed additional support when restrictions were being imposed. And lastly, I would just reiterate the points I was making before about, the third sector. I strongly feel is a really valued from people that we spoke to. They often described the access they were still able to have to support through the third sector as some of the positive experiences that they described when they were talking about their health and well-being during the pandemic. It's a vital contributor to our health and social care system, and it's not treated as such in the funding decisions that are made and in the strategic decisions which are being made nationally and locally. And I feel that our response to public health emergencies is enhanced by a strong third sector, and I think that's something that we really need to be considerate of when we're thinking about the lessons we need to learn.
Ms. Redmond, those are all the matters that I want to discuss with you. Thank you very much from my perspective for obviously the care that you put into your statement and the care that you've given to your evidence today. We're very grateful to you.